increase the dose based upon the patient need.
Thanks, Roman. This is Dustin. From a healthcare economics perspective, this is actually unique. You've got the efficacy story and value that Roman just mentioned. But also, if we look at the current marketplace, as you mentioned, and physicians have told us, most patients come back 3 to 4 times per year. With the current efficacy profile, what we're seeing here on the slides is that this potentially has an opportunity to cut at least 50% of those, or excuse me, up to 50% of those off. So that means the patient would only have to come in twice per year. This generates a significant economic value for payers, both from an injection fee, the amount of product that they use, and also other opportunities and costs that that patient may have in the office. So we think this would have a very positive impact from a payer perspective as well as a reimbursement perspective. And then on the biosimilar question you mentioned, that would perform similar to the current neuromodulators that Roman talked about, which is going back to 3 to 4 visits per year. So we wouldn't see that had a major impact on the actual value, both economically or for the patient, for daxibotulinum. Thank you.
This is very helpful. And just very quickly a follow-up. Have you disclosed the timing of the BLA filing, or I guess the sBLA filing for the cervical dystonia indication, or will you be waiting for the readouts of the other treatment trials?
What we basically said is that we expect approval in 2023. Obviously, with this encouraging data, we'll continue to, advance the program as, quickly as we can. We talked about, wrapping up the ASPEN OLS trial, but currently our commentary stands of a 2023 approval.
Thank you, and congratulations again on all the progress.
Great. Thanks so much.
Our next question comes from Terence Flynn with Goldman Sachs. Your line is open.
Hi, good morning. Thanks for taking the questions. I know you touched on this briefly, but was just curious to understand a little bit more about the prior response to Botox in your trial. So if you looked across prior response, was there any difference there that's notable, or was it pretty similar? And then I think in the prior, previously you've talked about a $200 million opportunity here for cervical dystonia. Now it's $340 million. So just wondering, what drove the increase here. And then the third question is, would be interested to hear if there's any update in terms of a manufacturing inspection for your Daxi facility in California ahead of the November PDUFA. Thank you.
Great. Thanks, Terence.
Yeah, thanks for the question. So allow me to clarify the prior response question. So as I mentioned in the baseline characteristics, at the when patients were screened for the study, a question that was asked was, have you had prior toxin therapy for cervical dystonia? Patients were not required to have responded to a neurotoxin for the treatment of cervical dystonia to be eligible for entry into the study. The study basically took all comers independent of prior response. I did mention, however, on slide 14 that for the Botox study, there was a prior response that was required for entry into that study of at least a 30% subjective improvement. And as you can probably assume, the cohort of patients that were then enrolled into that study were known to be treatment responsive, as opposed to a study that did not require that, which would have a mix of neurotoxin responsive and neurotoxin unresponsive patients. So again, our study was an all-comer study and achieved a median duration of up to 24 weeks compared to the data that's presented on slide 14, which showed Botox and evaluated subjects, only those subjects who had a response. I think the more fair evaluation of Botox would be to look at their label and their pivotal study, where the majority of subjects returned back to baseline by week 12 or 3 months.
Thanks, Roman. This is Dustin. I'll take the next one on market size. As you know, if you look at the external data reports, they get updated from time to time, and the most recent one came in September of 2020, and that update was the botulinum toxin global market trajectory and analytics report, and that report showed an increased valuation of just kind of how the CD market looked. So it's basically just an updated data. It's a fresher market report that came out in September of 2020.
Thanks. And then, Terence, this is Mark for your last question. It's company policy not to comment on sort of our regulatory status on that. Again, this call is very focused on the cervical dystonia data, and we'll have a more comprehensive update on our upcoming earnings call. Great.
Thank you. Our next question comes from Tim Lugo with William Blair. Your line is open.
Thanks for taking the question. Congratulations on the data. Roman, just to dig down a bit more into the baseline criteria, is it safe to say about 15% of patients were Botox or botulinum toxin naive in the study, if I'm looking at slide 11 correct?
Correct.
Okay. And how many of those who were experienced would you consider undertreated versus maybe the overtreated patients that you alluded to earlier?
You mean undertreated versus overtreated relative to the treatment group that they were assigned to?
I guess overall entering the study.
So entering the study, it's a good question. We can look to the literature to provide some clarity there. I would say that in general, the patients have to, in order to respond to the treatment, have to see a provider that's very experienced in the administration of neurotoxins for this condition. It's a quite complex condition in terms of the presentation, as well as the number of muscles and the location of these muscles for treatment. So there are a proportion of patients who do not receive satisfactory response and therefore drop out of the treatment population because they feel like it, quote unquote, did not work, but in reality, the treatment was not optimized for that given patient. So I would say that although we don't have hard numbers, there probably were a subset of patients just by virtue of the expertise of providers that are available to administer this type of therapy that potentially were not optimized going into the study.
Okay, interesting. Thank you. And how many patients rolled into the open label study? And can you remind me when the OLS is going to wrap up?
So we had a high proportion of patients who rolled over into the open label study. We haven't disclosed that number yet, but it was in excess of 85%, and we were very pleased with that because it shows the continuity that we were able to provide to these patients, as well as the data and over time in terms of repeat injections that we'll be able to report in the open label study.
Yeah, and Tim, we said that we expected 2021 to have that data.
Okay, great. And maybe one last one. I know that this was conducted during some of the height of the pandemic. Can you just maybe refresh with us any sort of protocol amendments which need to occur due to COVID, or what kind of percentage visits might have been impacted by the pandemic?
Yeah, sure. So it's a good question, particularly in light of the pandemic that we're currently in. So for the primary endpoint, which required data from both weeks 4 and 6, there were no study visits that were impacted by COVID-19. All of this occurred. The enrollment was complete back in October of 2019. In terms of the number of visits that were missed, they were very few, in the single digits. And for those that were missed, there were treatment assessments that were conducted for all of the key assessment measures, including twisters and the PGIC and the CGIC, and they were in the outer study visit week, so they had very little, if any, impact on the study outcomes.
Great. Thank you so much.
Thanks, Tim.
Thank you. Our next question comes from Annabelle Samimy with Stifel. Your line is open.
Hi. Thanks for taking my questions, and congratulations on the data. Just wanted clarification